In the field of hair transplantation, we like to say that you've never seen a great hair transplant, because if you can see it, it's not a great hair transplant. A great hair transplant looks natural, provides good density, and does not leave problematic scarring or donor depletion. Unfortunately, there's lots of bad hair transplants, and those are the ones people see and sometimes think represent hair transplants in general. There are two kinds of hair transplant surgeons: those that produce bad results and those that produce great results and fix the mistakes of others. To help me dive into this challenging topic, I'm going to one of the most respected hair surgeons in the world, Dr. Jim Harris.
Hi, I'm Dr. Robert Haber, hair loss expert and hair transplant surgeon from Cleveland, Ohio. Join me and the Hair Transplant Road Show as I travel the globe seeking answers to important surgical and non-surgical hair loss questions from the true experts in the field.
So today, the Hair Transplant Road Show travels to the mile-high city, Denver, Colorado, where my guest is Dr. Jim Harris, admired throughout the world for his innovations and expertise, particularly in the area of FUE surgery. Jim is a clinical instructor at the University of Colorado School of Medicine. He's a fellow member of the ISHRS, certified by the American Board of Hair Restoration Surgery, and served as its president, and has served the ISHRS on the Board of Governors and is member and chair of multiple committees. Jim is a winner of the Golden Follicle Award for his clinical contributions to the field, in addition to many other awards that he's won over the years. And he's an inventor holding 4 patents for inventions related to FUE harvesting. Jim has been a featured lecturer at meetings all over the world, has authored dozens of textbook chapters and journal articles, and there's really no topic that Jim is not capable of addressing expertly, and I'm delighted that he's agreed to discuss the important topic of repairing a bad hair transplant. Hi, Jim.
How are you doing, Bob? It's great to be here. That's a very kind introduction that you've provided, but I'm happy to be here to talk about repairs for hair transplants and less than great aesthetic results.
Everything I said is true, and so it's nice to be able to promote people that are major figures in our field. I first like to give my guests an opportunity also to say a few words about their practice. I know you recently had a major change in the way you practice. Tell us a little about your current situation.
Sure, I'd be happy to. So I've been in practice for about 25 years, and about a year and a half ago I started thinking about what my future is going to be. A little burnt out in the management aspect of a single physician practice. And I recently merged with a practice out of Chicago called Restore, a very busy practice that was made infamous or famous by transplanting some prominent athletes, Brian Urlacher to be one of them. And after the merger, I became the medical director for their practice and mine. We're in the process of expanding. We have a practice in Dallas. We're about to start one in Charlotte, possibly Southern Florida and Southern California. So we're growing. There's certain challenges to this, but I'm really looking forward to my new role as medical director for a multi-practice group. So it's very exciting for me.
And they're lucky to have you, without question. I think it's going to be a great success. It's so much easier, I think you'll agree, it's so much easier to create a great hair transplant from the start than to correct someone else's mistake. What sort of problems do you see that require repair work?
So you're absolutely right. It's better to get the transplant right the first time, but unfortunately there's people out there that have had two circumstances that lead to a need for repair. I'd say the first one happens to be old transplants, and it's not that anything was done wrong necessarily, it's just the technology at the time wasn't what we have now. Problems such as old plugs, flaps, scalp reductions, things like that, that at the time seemed to be great ideas, but over time we've realized that maybe perhaps they weren't the best methodologies available, but that's all they had. The second class of problems really have to do with improper surgical technique. So these days we have follicular unit transplantation, whether the harvest method was strip or FUE, but that doesn't mean the physician still can't make a mistake, or in some cases technicians who are allowed to do surgery, and that's a whole other story. But you can still have the best grafts in the world, but if your technique isn't right or your attention to detail isn't correct, you're still not going to get an aesthetic result. So those are mostly the two types of situations we see currently. And fortunately, because of the newer techniques, I'm not seeing quite as many repair cases come through my door. And that's somewhat of a relief that at least some people are out there learning. In addition to that, we do have institutions and groups such as the International Society of Hair Restoration Surgery that's very active in providing seminars and teaching avenues for physicians that want to learn more about the specialty. And with those opportunities, I think the physicians that may be going into hair restoration are better educated and have a better handle about how to create aesthetic results.
Well, we certainly hope that's true anyhow. Yeah, I mean, the old plug technique, although it didn't look good, these were done by practitioners that actually had a lot of skill and training. They were at the top of their field. Like you said, it doesn't hold up to today's standards, but then it was state of the art. And today, the mistakes the errors that I see are more practitioners that haven't taken the time to get skilled and have training or have the ethics to do good work.
I agree. Again, state of the art 25, 30 years ago is different than it is now. And I think if a transplant was done back in, 25, 30 years ago with the tools and methodologies they had to work really hard and be highly skilled to make it look natural. And I've seen some amazing work, but that doesn't mean over time it doesn't degenerate to some degree. People continue with hair loss, exposes old plugs and patterns and so forth. So even the surgeries that was performed to the best of their ability can still sometimes degenerate over time. Again, I agree with you that these days the situations that we see that require repair are a little bit different. And unfortunately, we are seeing some of the results of some of the transplants done overseas, and specifically some of the black market clinics as we refer to them.
And old plug work, I think, was relatively easy to correct too, because you just take those out and cut them up into smaller pieces and put them back in, and they did fine. And we did a ton of those, in my practice a decade or so ago. And most of those repairs, I think have been performed, or people are maybe getting a little too old to care as much, since some of those were done 20 or up to maybe 40 years ago. And what I'm seeing is overharvesting of the donor area and poorly designed hairlines, and those are so much more difficult to correct.
I agree. The amount of grafts and the locations that they're being placed are really problematic. So we can start breaking them down if you'd like right now. So when we're talking about, let me step back here just a moment. So I want to present my approach, if that's okay. So if a patient comes into my office and says, hey, I'm not thrilled with the surgery I've had. And so it's incumbent upon me to listen to their story. What bothers them? I might look at their scalp and see something that bothers me, but that may not relate to what bothers them when they look in the mirror or when the wind blows. So it's really important to get a sense of what they're feeling and what they want corrected. And so I'll listen to what bothers them, talk to them about the past surgery they've had, get some idea of the number of grafts they may have had removed. And then following that, then I'll take a look at the patient's scalp, so I can verify, in fact, what they're feeling or seeing when they look in the mirror. I can diagnose that. Is it improper location of grafts? Is it improper placement of the grafts in terms of angles or directions? So there's certain guidelines that we use, obviously, that about how to create a hairline, where an appropriate placement is. And so you get a sense of what's bothering the patient, and that's going to dictate what your eventual plan might be. So I've had plenty of patients that have come in that describe certain issues that bother them, but I'll look at the hairline or a different part of the transplant and see a completely different story. So a lot of times we have to mesh the two opinions, the patient's opinion and the doctor's opinion, about the correct way to go about to accomplish a repair.
I think we've all made the mistake earlier in our career of having someone come in and will say something like, oh, that looks terrible, who did that? And the patient will say, what do you mean, doc? I love it. I just want more density. And like, oops, So we learned very quickly.
Always listen to your patient first.
Tell me what you think about the procedure, and then we'll proceed from there. You only want to get your foot in your mouth only once in your career.
I agree. There's also the situation where patients will come in and they're perfectly fine with, say, the frontal hairline, and even though it looks linear or too pluggy to me, their primary concern might be a under-transplanted crown or something where they have grafts in the middle of a wide open space, and then they'll they'll have a correction but don't want to touch the frontal hairline. They'll tell people that I did a great job and I corrected their transplant, and yet they still have a frontal hairline that I would not want to be associated with. So you have to tread lightly with these patients because certain things that bother them, again, may not be something that the doctor notices or thinks the highest priority. So it's a little bit of a negotiation. And you're right, you don't want to step into something that you don't need to.
And we do have a saying, right, that the last person who touched the patient is responsible for the appearance. So we're very cautious sometimes about trying to do the repair work because that's going to be the last doctor that they mention, and we don't want some horrible hairline to be, oh, that's Dr. Haber's hairline or Dr. Harris's hairline, and yet we want to really help them, and that's a conundrum. We have to be careful about that.
I agree. So, Doctor, I'll toss this out here. Dr. Vance Elliott in Vancouver has presented his algorithm for evaluating past transplants, and I find it very helpful. It's called the P.A.S.O, and basically that stands for position, angle, shape, softness, and then other problems that you might notice. And I think it's a reasonable thing for a physician to use to evaluate someone else's work, and certainly when a patient presents themselves, to look at it critically in a very systematic way. So the patient standing in front of me, I'll just take a look at their general appearance. Again, the shape of the hairline, the location, look for specific problematic areas, in other words, size of the grafts, directions, angles, and so forth. And then I'll work systematically from the frontal hairline to the forelock area, looking for the distribution. Is it, do they have an area of central density? Is that lacking? And then move posterior to that to the mid-scalp region, and then back towards the crown. And again, this is somewhat guided by their areas that they're mostly concerned about, so I'll focus more on those to get an entire picture of what the transplant area looks like. Then following that, then what we're doing is looking at the resources that they have to repair. So that would be remaining donor density. In other words, do they have enough hair in the scalp donor region to affect a transplant? Do they have scalp laxity in case I need to do a scar reduction or take out more grafts via strip? So you're looking at the resources, and then in a discussion with the patient, you're also looking to see what they're willing to do. Some of my patients have had to wear a hairpiece or hair additions for a long time. Are they willing to not wear that for a while to achieve the result that they want? Are they willing to shave their donor area? Are they willing to have another strip surgery? Are they willing to use body hair? So all these factors are a matter of discussion with the patient to see what they would allow you to do in the terms of the surgery that would affect their immediate post-op appearance. So those are important factors as well.
All critical. Do you find one type of repair the easiest and one the most difficult? What do you dread most? Patient coming in and asking you to fix?
Well, I think at this stage of my career, I think I've developed enough of an armamentarium that I'm pretty confident that I can take most people from something that looks not so great to something that looks, at least doesn't appear to be a botched hair transplant. I think some of the most difficult ones are the patients that have had significant numbers of grafts in the past that are maybe larger, and the problem with that is if they don't have enough donor capacity to at least camouflage it to some degree, and you're stuck without a lot of resources. And I find those the toughest because the options quickly dwindle if they don't have enough existing donor capacity to either go in between the old grafts, to give it at least a moderate density to cover some of the old scars from the old plugs, the 4mm plugs that they used to do. I think those are some of the most difficult. But if you combine that with, say, a hairline that was placed much too low, then that constricts your capabilities as well. And in those cases, you may be looking at a more invasive type of procedure. Say if the plugs are down at 6 centimeters above the glabella, then then your options are much more limited, and you're going to have to take those grafts out pretty much either one by one or excise them all at the same time. And when you talk to patients about that, it sounds much more invasive and maybe more than they're willing to do. But again, that you just have to determine with their input what's most important to them and what they're willing to do.
Some repairs don't really require more donor. If their hairline is down or angled, it's a question of putting that in the right place. And if they're not going to get a forehead lift, which is certainly one way to do it quickly, as you said, the only way to do is to remove them one by one. And it's so much harder to take out graft that's been placed wrong than to take out a graft that was growing naturally in the back of the head. And it's expensive and it's time consuming. How do you approach a patient with follicular units, not plugs, that are placed 5.5 centimeters and angled? What's your approach for a patient like that?
So I've been pretty successful in using FUE. FUE has revolutionized, I think, my approach to the repair of these old transplants. I've been pretty successful in removing grafts in their entirety, several centimeters. It may take more than one procedure to do it, because one of the things we run into is that there are scars around these follicular units that may be too low or misdirected. And so the scar tissue makes it a little bit harder to get the grafts out. But what we've been able to do is remove up to 2 centimeters of grafts, even more than that if we need to either correct a misplaced hairline that's, say, entirely too low, or if we need to remove the grafts because they were misdirected. In other words, sometimes we see in the temple region here, the grafts are placed incorrectly and they tend to stick out to the side rather than lay flat against the skin. So typically I use FUE to remove as many grafts as I possibly can. Now, in addition to that, there's other patients that are tired of surgery. They just don't want anything anymore. They just don't want the hair that was placed too low. And there's some non or minimally invasive ways to get those out if they don't want to have FUE to do that. You can also consider, some things like ablative things like laser hair removal or electrolysis, something like that. But if they've lost hair and they've gone through the effort to have a hair transplant, most of them want to keep the hair and they want to put it in a different location that's more appropriate. So again, this all goes back to what their original desire was when they walked into your office. A hairline that was too low. If it's follicular unit grafts with FUE, I'm perfectly able to remove those. And again, maybe it might require more than one session, but we can take those grafts and move them to a different location to create more density, say in the back, and then get their hairline to the position that they want. FUE has also allowed us to go into situations where the patient has, say, 4 millimeter plugs or even smaller than that, 2 millimeter plugs, and it's allowed us to debulk those. In other words, we can, if a graft has 4 follicular units in it and it seems to look pluggy, we can actually remove 2 or 3 of those follicular units, recycle those, use them somewhere else, but not disrupt the original graft that went into place. So that has really made the repair process, a procedure that works quite well using the FUE technology.
I totally agree. FUE was a game changer for repair work without question. We hair surgeons are loath to kill a hair. When the idea of doing electrolysis, we're killing the hair. Laser hair removal, we're killing the hair. We don't like to do that. We want to take it out and reuse it someplace. But sometimes the patients, for a variety of reasons, don't want that, and those are perfectly acceptable ways. Ideally, if they have a good, robust donor supply. It's even harder when people want to do that and they've been somewhat over-harvested. How do you approach a patient that's been over-harvested in the donor area?
So I think, that's a really tough problem. So the over-harvesting can be of 2 types. One is general over-harvesting of the entire donor region. That is the most difficult to deal with because obviously they're left with a very thin appearing donor area. They don't have a lot of resources for repair. And then there's over-harvesting in a patterned sort of way. So we saw that when the ARTIST robot came out for a while, people were using this tension device that kind of restricted the harvesting to smaller areas, and they would tend to go back in there multiple times, and it would create a pattern. So if the overharvesting maybe is not so egregious, but you notice areas of low density, part of that repair may be to decrease the areas of high density by removing grafts from there. And then one of two things: either if those grafts need to be used on the top of the scalp for a repair, then those are available grafts. If they don't need them on the top of the scalp and their primary concern was the overharvesting and that's the repair that's required, you can actually take some of those hairs and move them back into the donor area to achieve a more even density. So those are two options. The second and third option, or third and fourth option, are a little bit different. So you can also take body hair from various locations. So beard and chest are my two favorite locations to obtain hair from. I've been doing a few cases with back hair as well. That seems to be pretty robust in some patients. And take the body hair and move that into the donor region. The problem with body hair is typically they only have one hair per graft. So to maximize the coverage with the body hair, you want to get the thickest hair possible. So not all patients, have super robust body hair, but typically the beard is a great location because the hair shaft diameters are usually about twice as what you might see on the scalp. So that makes for a pretty robust repair. The second option, which we've been utilizing quite a bit recently, is SMP, scalp micropigmentation. The problem with low density in the donor region and this overharvesting is that you see a lot of scalp. And obviously, if we can decrease that contrast by using SMP, I think that's really been a great methodology to help people that have had graft overharvesting from the donor region. It's also SMP, just while we're on the topic of SMP, it's also a great adjunct for the recipient area, the top of the scalp, to decrease that contrast between scalp and hair. So that's, a non-surgical way to affect some of the repairs that we need to do in situations with low donor capacity.
I agree. SMP has been a game changer as well. It just has that little safe thing that we can do to make everything look a little bit better. And like you're saying, the beard hair is the only non-scalp hair that grows long. So that's one of the advantages of using beard hair. It's more robust. It grows long, the chest, the arms, the back. It'll grow, but to short. So it's going to help camouflage a little bit, but it's not going to give a long, luxurious hair follicle, of course. I'm sure you face the issue of a patient consulting with you, then going to, we'll say, Turkey or some other black market area to save money, and they ended up in a black market clinic where poor work was done. Then the patient comes to you and says, "Hey, Dr. Harris, can you repair this work?" When you look at him, you say, "I could have done a great work beforehand." How do you handle a patient like that had the opportunity to get it done right with you first and comes back to you for repair work?
Well, the temptation is to say, you got what you paid for. However, I don't do that. And I've had numerous situations where a patient has come to consult with me, ended up going elsewhere, specifically to Turkey or someplace that offered very low cost for a transplant, and you really feel for them. The hardest part is that you and I both know this, and most people that have done the research into hair restoration, is that the follicles are a limited resource, non-renewable, and unfortunately, if they go there and they don't get great growth, the tendency for these clinics is to harvest an immense amount of hair, at least in one procedure. I think you may have mentioned this, but there were ads out there for unlimited number of grafts for $4,000 or $3,000. Well, we all know that you don't have an unlimited supply of grafts to transplant. So unfortunately, when they've come to me to effect a repair, a lot of times their donor region is overharvested and they don't have a lot of resources left. And so what I do is kind of what we've been talking about. I'll look and see what bothers them about the transplant. Typically, I see very low hairlines, very, very broad, and those obviously tend to suck up a lot of grafts. And so if I can utilize some of those grafts that did grow and remove them from the inappropriate location to create density somewhere else, top of the scalp, frontal hairline, we'll go ahead and talk about that. If they had a reasonable number of grafts extracted, maybe got poor growth, I'll assess their donor region to see if they have, additional grafts available, and they're certainly a candidate for more, then I'll go ahead and recommend that for them. SMP is a big help with these patients as well. Again, they tend to be over-harvested. I've seen some patients with pretty reasonable growth, but it just so happened that a lot of the good growth was in inappropriate locations. And I think when patients go to some of these clinics, they think it's a great idea to have a hairline, placed pretty aggressively low on the forehead. And then when they come back and they actually look in the mirror after it grows, it just doesn't look quite right, depending on their age, of course, and the density. You can't have a low hairline with super low density and have it look fantastic. So by the time they get to me, they're pretty open to whatever my suggestions might be, and I always have to counsel them on the fact that, look, you've used a lot of your donor capacity, you didn't get great results, poor growth, typically, and you're going to have to accept a long range appearance of something that may not be what you had in mind when you first started to go into looking for a hair transplant.
It's always surprising to me. Some of these doctors have great technique that all the hairs are growing. They're just all growing in the wrong direction.
Yeah.
So they have the ability to get these hairs out and let them grow, but they have no aesthetic sense whatsoever. They come to a couple of meetings, go to some lectures, and all of a sudden, they're going to do some much better work. It boggles my mind when people do a cosmetic procedure, but they don't have an aesthetic eye.
Right.
And working in the back, we have the conundrum of FUE is the traditional safe zone, which is that zone in the back of the head that strip surgery was always taken from. And if all the FUE grafts are taken from the traditional safe zone, you get a window. It doesn't look good. You have to go above and beyond and below to homogenize. But then we may be harvesting grafts from areas where, if hair loss progresses, those hairs can be lost. And those are touched on some of the other programs. So it's a little bit of a conundrum that we have in terms of how to appropriately and cosmetically, but also ethically, use the donor area.
I agree 100%. I mean, I think, when we first started doing FUE, we were very strict about what the safe donor zone is. And I think over time we've realized that without relaxing some of the rules that we had about the safe donor zone, you can actually create something that's very unaesthetic. And so you have to use your judgment in terms of how you want to deal with that. But I think some tapering into some of the areas that are not traditionally the safe donor zone is absolutely essential, or else you're creating a complete different problem there. I agree with you about I've seen some pretty good growth, but again, part of what we do as hair restoration surgeons is we want to make sure that the growth that we do accomplish is natural in appearance. And we have to follow the rules that have been established developed over the last 50 years about how to do that. And so that's the main role of the physician, I feel, and you probably address this with other doctors, but we have a lot of staff members that we're watching that help us do these hair transplants. And if they're not taught properly because the doctor doesn't know how to do it, then it's not going to work out. Hair direction and the curvature is very important to nail. The way the sites are made to make hairs go in the direction you want them to go. In the temples, they have to lay flat and so forth. And if those things aren't done or addressed properly, then that's the role of the reconstruction. You're absolutely correct. And FUE has helped with that to such a significant degree that we can actually access so much of that hair that was misplaced and remove that and then replace it in an aesthetic manner. And we can do that in the temples, the frontal hairline, any place that we notice these issues or the patient notices these issues.
We've touched, it's not really the focus of this program, but the black market, one of the problems is a doctor's not doing the work most of the time. It's a technician who has never been to a meeting, who's never had proper training, who's learning a technical skill, but doesn't have the big picture. And the inappropriate delegation of critical tasks in our field is a huge problem, and particularly a problem in offices where people just want to make a little quick money and they think hair transplant is easy, and it's not. As you and I know, it takes a long time to master each of the steps, and inappropriate delegation is just a recipe for disaster.
The time that, say, for example, you and I've spent on perfecting or at least trying to achieve perfection, say, in the frontal hairline design, not only the location and the general position of it, but how do we create a hairline that looks, as close to the way nature intended as possible. And, you and I have spent our career. I still critically evaluate my work every day and wonder how I can do better. And you just mentioned these clinics that hire in people that have never had formal training, certainly never see their follow-ups for the most part, out there doing surgery, and that's creating this whole situation that we're seeing now, where a lot of our repairs these days are correcting the work of basically untrained, unlicensed people that have never learned how to do this type of procedure. And I hope we see less of it in the future, but it's still certainly a problem.
I don't know, I assume it's true for you, but I'm constantly looking at people's hairlines. I'm constantly, whether I'm at the grocery store or anywhere, I'm looking at natural hairlines, because natural is not just one hairline. There's so many natural hairlines. And I'll see a hairline that's interesting and say, well, I could create that surgically, and that's natural because it looks good on that guy, and that's his real hairline. So I'm constantly looking at hairlines. And all you need to do is look at nature, and you're not going to create these disasters, because that we never see in nature. And you just have to pay attention to what some of the good stuff that nature does, and we'll stay out of trouble.
I agree. So Manny Merritt, my mentor and teacher, and the doctor I took the practice over from 25 years ago, he had an issue with people saying that it's all artistry, that we're artists, and his rub with that is that we're not trying to create something new or something that's never been done before. We're artisans. We want to reproduce what nature does. We're not trying to create something, just so unique on your head that, you're the only one to have that. That's not what we're trying to do. You're exactly right. We're trying to mimic nature. And the way you do that is to look and see what nature has done, and to the best of our ability, try to recreate that. That will decrease the need for repairs and, all the things we're talking about right now, if people would just do that, if they just got the training properly.
P.A.S.O probably would not have made a great hair transplant surgeon. So it's not all artists should be surgeons. Now, strip harvesting leaves wide scars too. I mean, strip harvesting techniques and scars are so much better than they were years ago. But once in a while, a patient will have a wide scar. That's just sometimes the way the skin heals. You can do a number of things for a wide scar. What's your approach for someone who comes in with a wide scar?
So, yes, you're exactly right. That's a second type of problem that we see in the donor region, excessively wide scars or too many scars. Usually the first thing I'll do goes back to the history of the patient, and I'll first ask the patient, if he comes in and says, I have a wide scar, I'll ask him about the surgery or surgeries that he's had. So, as you and I know, that wide scars are somewhat more frequent in second round strip surgeries. In other words, they've had one strip surgery, a doctor's gone in, removed a second strip, straddling the old scar, which is what we try to do most of the time. But if there was a misestimation of the laxity of the scalp and it turned out to be tight, they may end up with a wide scar. So that's possibility number one, is that the scar was iatrogenic in nature, maybe some misjudgment on the surgeon's part, and the wound was closed under tension. So that's one category that I would try to ascertain. The second might be the issue where a patient has had one surgery, great laxity, no trouble closing the wound or anything, but due to the characteristic nature of that person's skin, and it's usually people with hyperlax skin or underlying connective tissue disease, they'll end up with a wide scar no matter what you do. So the way I approach them is, if a patient has had a single surgery with a normal laxity and yet ended up with a wide scar, if I look at it and see, say for example, the scar might be wide in a certain location, and typically we see that in the postauricular area over the mastoid. If the patient has regained decent laxity and I think I can remove the scar in its entirety, I will try one time to do a scar revision. If the patient has already had a scar revision and still ended up with a wide scar, I don't even attempt a third one. I just assume that the surgeon tried his best, and if they've already had one scar revision, they've already used up additional laxity. I'm not going to go in there and do that. I will look more towards camouflage techniques such as either scalp or beard into the scar itself, or SMP, or a combination of the two. If a patient has come in again with a wide scar, they've had a single surgery, and it appears to or feels to me that the patient has hyperlax skin, that's a little bit of a coin toss for me. I'll talk to the patient and let them know, well, this is what I'll tell them, is that I can try scar revision if this wide scar was due to an issue of a hyperlax scalp. It's likely to recur. There may not be much lost, but I think the risk is relatively high that you'll end up with the same type of scar after revision. I'll talk to them about, rather than trying a scar revision, let's just go ahead in there and think about transplanting into the scar with either available scalp donor hair or beard or chest, along with SMP.